Now that we have a general idea about what biochemistry is, let's take a moment to think about the significance of biochemistry and why it should be studied. The thing is, biomolecules and the metabolic reactions and the pathways they participate in, along with the cells and tissues of the body, form the machinery of the body, the essential nuts and bolts that make the whole system run. Just to give you an analogy, studying biochemistry is like popping open the hood of a car and looking at the engine that actually makes the car run. Here's a nice pictorial representation of that analogy just to drive the point home and also to provide our viewers with some visual relief, after they have been made to look at all that text. Now let's move on to clinical biochemistry, which is the actual focus of this course. So clinical biochemistry deals with the study of biochemical reactions from a clinical viewpoint, that is, with a special emphasis on diagnosing diseases, making prognoses, and devising appropriate treatment regimens for diseases. In contrast, non-clinical biochemistry is more research oriented and it is not involved in patient care to the same extent as clinical biochemistry. Metabolic derangements can be both the cause and the result of diseases. For example, derangement of glucose metabolism results in diabetes mellitus. And then you have something called the Warburg effect, which is a consequence of cancer. What happens is that the Warburg effect actually refers to the preference of tumor cells to utilize the pathway of glycolysis for generating energy even in the presence of adequate oxygen, because normally glycolysis happens in the absence of oxygen. So what this does actually is that it provides energy very rapidly and it also generates lactate, and both these changes facilitate the rapid proliferation of neoplastic cells, which is a hallmark of cancer. Abnormal biochemical test results can pinpoint a specific disease, or it can narrow down the differential diagnosis to a few possibilities. For example, if you have an elevated level of HbA1c, which is glycated hemoglobin, above 6.5%, then that makes a definitive diagnosis of diabetes. And if you have elevated levels of serum creatinine and blood urea nitrogen, that points to renal injury. Now, there can be a number of different causes which can cause renal injury. These could be pre-renal, for example, heart failure, or renal causes such as chronic kidney disease or acute tubular necrosis, or they may even be post-renal causes such as urinary tract obstruction. There are now a large number of tests available to detect a very wide variety of such abnormalities. Biochemical tests have now become a staple of modern clinical practice and they are conducted for practically all patients. Some of the most common tests are as follows. First of all, you have the TLC, the total leukocyte count, which is raised in infections. And then you have the differential leukocyte count, which indicates whether the infection is acute or chronic. Hemoglobin levels, which help in detecting anemia. Then you have the liver function tests like ALT, AST, albumin, etc., which check for liver damage. And the common renal or kidney function tests are serum creatinine, blood urea nitrogen, and plasma levels of sodium and potassium, which check for kidney damage. So in the era of advanced biochemical tests, what exactly is the clinician's role? Let's examine this question. The clinical's role is to first of all form a provisional diagnosis on the basis of history and examination. After that, the physician is supposed to order appropriate biochemical tests that either confirm or refute the diagnosis. Note that the word appropriate here is important. Then the clinician is supposed to interpret the test results correctly, make an informed opinion, and plan the future course of action accordingly. What that means is that if the diagnosis is correct, then devise a suitable management plan. Otherwise, think of other possible diagnoses and re-evaluate the patient. A cautionary note here. Biochemical tests are meant to aid and supplement clinical skills and judgment, not replace them. It's not advisable to skip the clinical judgment and straight away, order a barrage of tests for the patient, hoping that one of the results will come back abnormal. That is a little bit like shooting in the dark and hoping that, you end up hitting the target by accident. That approach is wasteful. It wastes both time and precious resources, and it also inconveniences the patient by subjecting them to unnecessary and sometimes painful tests, and also by running up their medical cost, by running up their hospital bill. Rather, the physician should actually use lab tests to support the conclusions that they have reached on the basis of their clinical examination. Lastly, we are going to look at some actual scenarios that illustrate the relevance of biochemistry in clinical medicine. First, we have edema, which is the appearance of swelling in the body due to accumulation of fluid in the subcutaneous space. You see, if the swelling is generalized, which means it is spread all over the body, then a likely cause of the edema is hypoalbuminemia, which is just simply a low level of albumin in blood. Now, chronic liver disease is an important cause of hypoalbuminemia, and also chronic liver disease is very commonly seen in alcoholics. So, if an alcoholic patient who presents with generalized edema has albuminemia, you should immediately suspect chronic liver disease and then perform appropriate tests to confirm the diagnosis. The other thing is that malnutrition can also cause hypoalbuminemia, and that is actually also very common in chronic alcoholics because generally they have a very poor diet. So next we come to jaundice. Jaundice is the yellowish appearance of skin and sclera due to excessive bilirubin in blood. Now, bilirubin exists in two forms, unconjugated and conjugated, and only the conjugated form is water soluble, and it is also the only form which is excreted in urine. Now, levels of conjugated bilirubin rise only in hepatic and post-hepatic causes of jaundice. Hepatic causes of jaundice could be hepatitis or liver cancer, and post-hepatic causes are any causes which cause obstruction of the bile duct, for example, gallstones. And unconjugated bilirubin levels rise in prehepatic causes, but in prehepatic causes there is no rise in the level of conjugated bilirubin. Normally there is no bilirubin in urine, and if you do find some bilirubin in urine, you can be certain that it is conjugated bilirubin, because like I said earlier, only conjugated bilirubin is water soluble and excreted in urine, while unconjugated bilirubin is not. So the appearance of bilirubin in urine indicates a hepatic or post-hepatic disorder, not a prehepatic disorder. So that concludes this lecture, and in the end I would like to summarize what we have studied today. We looked at the definition of biochemistry and the definition as well as the major classes of biomolecules. Then we looked at the definition of metabolism. Then we discussed the importance of studying biochemistry. And lastly, we had a look at clinical biochemistry, specifically its definition, the proper way to apply biochemistry in clinical practice, and also some specific examples that illustrate how the knowledge and tools of biochemistry can aid in clinical work. I sincerely hope that this lecture was informative and engaging for you, and I would like to request you to stay tuned to this channel because new content is coming very soon. Thank you.